¿Qué tal? Muy buenas noches. Yo soy el doctor Javier Melchor y seré el moderador de esta mesa redonda. Es un placer estar el día de hoy aquí con ustedes. Ya el doctor Luis Montiel previamente presentó a nuestros panelistas que realmente son personalidades internacionales con respecto a la cirugía HPV. Es para mí un placer estar aquí compartiendo el foro con el doctor D'Angelica, el doctor Federico Aucejo, el doctor Mario Uribe y el doctor Felipe Fernández Coimbra. Bienvenidos a todos y comencemos con esta mesa redonda. Realmente vimos dos posturas muy interesantes. Actualmente sabemos que hay muchas controversias con respecto al trasplante hepático en metástasis de cáncer colorectal. Y bueno, a mí me gustaría empezar con el doctor D'Angelica unos minutos con respecto a, en términos generales, lo presentado por el doctor Federico Aucejo, si tiene alguna réplica. Doctor D'Angelica.
Well, I think it was an excellent lecture, and I think Federico is developing an experience based off of the experience at University of Oslo. And so far, I think it's been quite successful. The arguments that I made against transplant, really not because I'm against the idea, only to just illustrate that there is a controversy, were that selection is everything. In oncology, selection is just about everything. And so there are a very small group of patients who can probably benefit. And as Federico knows, I've probably referred more patients in the United States for transplant than anyone. But I think that's a very rare indication in young, healthy people where you can obtain a liver graft. Many of them, as Federico showed you, have developed liver disease from their treatment. They've developed portal hypertension or even cirrhosis from chronic chemotherapy or radiation or combinations of all the treatments. So I think it's a great talk. I think it will play a very small role, but a real role in the treatment of this disease. And I'm glad that it's actually come back in some way. But one thing we do have to realize, many of these people, as you've seen, will recur. It's for the young person who really is desperate to live as long as they possibly can, even if the disease will come back. So that's my commentary.
Muchas gracias, doctor Aucejo. ¿Algún comentario con respecto a lo comentado por el doctor D'Angelica en su plática?
I have to say that we have more in agreement than in disagreement with Mike, because as he pointed out, we have to be clear that the applicability of liver transplantation for this indication will be, for a very highly selected group of patients. So that's a small group of patients. And we need to understand that transplantation is the very last option, surgical option, that these patients could have. And, although most of the selection criteria elements are, we could say, rather rudimentary, but some of them are actually important, and they show they can work. I wanted to underline the value of the test of time. So those patients who have a rather indolent evolution of the tumor over time are going to be the best patients that can be selected for this. Those patients who show a good response or stability of the disease in response to the multiple treatments over the time are the patients that are going to be the best to be selected for liver transplantation. And I want to say that, and this is in line with, if we can establish a comparison with what has been done by the Oslo group, which my understanding is mainly those patients have received systemic therapy. And in our brief experience, we have had the chance not only to use systemic therapy, but also heavy utilization of local regional therapy, including radioembolization, microwave ablation, external beam radiation, And the combination of these therapies are key, and the response to these therapies, radiologically speaking, not only by RECIST criteria, but also by the metabolic activity of the tumors, how they respond to this therapy is very important. So, bottom line is, yes, it's a therapy that we can see that can work, that can help people to survive beyond the standards that we see with systemic therapy when surgery is not an option. But we have to be very careful in the patient selection criteria, and moving forward is going to be very important to work around in the sense that there is room to improve it by incorporating biomarkers, molecular biomarkers. So we don't know what is the potential role of circulating tumor, cancer cell, DNA, or aberrant patterns of methylation in circulation, or the combination of somatic tumor mutations. How all these elements can help us to improve better, to improve and make a better patient selection towards transplantation. So I agree with Mike. This will only apply likely to a small group of patients, but definitely can improve survival. And I think there is room to make it even better.
Está con nosotros el doctor Mario Uribe. El doctor Uribe tiene una gran experiencia en trasplante hepático. Me gustaría conocer cuál sería su perspectiva o cuál es la perspectiva en Latinoamérica para la implementación de un trasplante hepático oncológico.
Bueno, primero que nada, muchas gracias por la invitación. Por supuesto, me encantaría estar en México compartiendo con su extraordinaria gente, sus paisajes, su gastronomía. Dicho esto, quiero decir que esta pregunta tiene dos componentes. El primero es la parte netamente técnica y los resultados oncológicos que se han planteado. Y lo segundo, y sobre eso me voy a extender un poco, es la realidad en Latinoamérica sobre el trasplante hepático. Chile tiene una tasa de donación de 10.4 por millón de habitantes y estamos aumentando porque hasta hace poco era de 6 y algo, con una mortalidad en lista de espera de más del 30% de pacientes que fallecen en lista de espera. Hay una comisión nacional integrada por una persona a lo menos de cada de los grupos trasplantológicos, donde basados en un lineamiento estandarizado sobre las indicaciones de trasplante, hay espacio para excepciones, fundamentalmente para donante cadáver. Y en Chile no se ha hecho nunca un trasplante para pacientes con metástasis hepática de cáncer de colon, y yo dificulto que con esas cifras podamos hacerlo en el futuro próximo, porque, como decía, no son solo las consideraciones que ya se ha hablado de los trabajos de SECA y OSLO, que tiene una realidad absolutamente diferente, pero con esos resultados creo que nosotros tenemos otras prioridades. Así, haciendo abstracción de eso, yo creo que los grandes avances en cirugía y en medicina se hacen desafiando los paradigmas, desafiando los elementos que se tienen, y yo creo que si hay una buena selección, creo que no es un camino que haya que cerrar, sino que es un camino que hay que investigar. Todas las cosas que en este momento se han instituido como algo, si uno piensa en el primer trasplante de hígado, en un principio pasaron por una etapa de bastante complejidad y de poca aceptación. Así que hay que escoger bien los pacientes y ver especialmente el rol que puedan tener los marcadores tumorales en un futuro y todos los aspectos genéticos.
Doctor Felipe Fernández, muchas gracias por estar hoy con nosotros. Me gustaría que nos hiciera favor de compartir cuál es su personal punto de vista con respecto al trasplante hepático para metástasis hepáticas, como primer pregunta. Y como segunda, le preguntaría por qué la baja reproducibilidad de la infusión arterial hepática fuera de Estados Unidos y de algunos centros europeos, y si esto es factible poderlo extender en Latinoamérica. ¿Cuál es su punto de vista?
First of all, thank you, Dr. Melchor, for the invitation, and I'm very glad for being here again. The third time I'm considering I'm in Mexico now, but not really, but maybe next year. And congratulations to all my friends from Mexico for this wonderful meeting. First of all, regarding the disease, I think we're talking about a very advanced disease here. So patients with multinodular unresectable disease, of course. And specifically for transplantation, I think there's a role, yes, and I agree with Mike and Angelica. Once most of these people, we still have some issues on selection and recurrence, but there are some specific patients that might have, and data is showing each time more some benefits from controlling the disease and long-term survival for these patients who once had an unresectable disease. So I think there's a role for very selected patients, and I think we are still understanding how to deal with this selection, but for sure, there are some patients who will benefit a lot from the transplantation. I agree. So that this will be a future a part of all the choices we have for colorectal liver metastasis in the unresectable setting. Regarding the hepatic artery infusion, it's not very common to have in Latin America. I believe, I know in Brazil, we don't have it available very easily. And there are some issues, of course, on greater complications during the in-hospital time and some biliary structure issues too. But we are talking about very advanced disease again. So I think I agree there's a role too for this very advanced disease in patients with colorectal metastasis. And again, I think selection will be the key. What we do here in Brazil, in our center at AC Camargo, we usually, of course, offer a neoadjuvant therapy for this advanced disease, and we are very surgically aggressive. And we have changed, as many centers in the world, the concepts of resection. So we changed, for example, the outflow concepts, sparing parenchyma in the side that we cut already the venous, the hepatic vein. And since we try to spare a bridge, a parenchyma between one side to another, and also preserving those posterior veins directly to the vena cava. And I think actually we are gaining different steps and gaining control of the disease a long time. So I think with these new chemotherapies and some drugs in combination that are coming and being very aggressively surgically and using all the possibilities we have, all these patients will have a gain in survival and disease control. So that's it.
Muchas gracias, doctor Aucejo. Con la experiencia que han acumulado hasta este momento en trasplante hepático, me gustaría preguntarle qué pasa con la calidad de vida. Un paciente que tiene un periodo libre de enfermedad tan corto después del trasplante, cuando menos en los estudios ya reportados, ¿realmente estamos modificando la calidad de vida de estos pacientes? Digo, finalmente tienen que utilizar más medicamentos, inmunosupresores. ¿Qué tanto estamos impactando en esta calidad de vida después de un trasplante hepático?
Es una muy buena pregunta. Desafortunadamente, lo que no... sorry, I'm going to switch back to English. It's a great question. So Mike can hear. So it's a great question. Unfortunately, we cannot predict how the recurrence is going to be, because we know that there are certain type of recurrences that are more, benign, if you want, like single unifocal recurrence in the lung versus multifocal recurrence involving the liver, for instance. So even in the event of recurrence, when we have a good recurrence, we have seen that those patients can be treated for those recurrences and have, if you want, a long survival and good quality of life. But again, we need to continue working on predictors to be able to anticipate which type of recurrence we'll be dealing with. And it goes back again to the selection criteria. And it's a very good point, the one that you bring, Javier, because of course, once these patients have recurrence, we know they're immunosuppressed. It's very difficult to treat this. And like the first patient I showed, what we learned about that first patient, if we learned something, what I learned was, so that patient got to the point of transplantation with multifocal still active disease in the liver. And she developed recurrence 6 months after transplant in the lungs, lymph nodes in the abdomen. There was nothing to do other than put her back on systemic therapy. So obviously, and at 2 years she expired, she died. So obviously the quality of life for that patient was very bad, and we really didn't help her much, right? But the other case that I showed, that patient who had a unifocal recurrence in the lung, who did have a resection, that patient is a little bit above 2.5 years from the transplant, is doing fine and no evidence of recurrence, at least radiologically. So it's a very challenging scenario. It's a very good question, the one that you have, and we'll have to improve as we go and as we learn, I have to say.
Muchas gracias. Doctor D'Angelica, ¿será que el poder ofrecer un trasplante hepático más allá del resultado oncológico, el ofrecerlo en un paciente que tenga falla hepática y cáncer, sea lo que esté abriendo este tipo de estudios, esta llave? ¿Qué opina? Vaya, creo que 2 o 3 pacientes del doctor Aucejo realmente se trasplantaron por falla hepática secundaria a quimiotoxicidad, más allá que buscando un resultado oncológico.
Yes, thank you, Javier. That's a really great point. And actually, what I wanted to continue to talk about, the examples that you see are patients who have survived a very long time without evidence of disease outside of the liver, and obviously they've responded to various treatments. And sometimes these patients get to a point where the toxicity of the treatment is actually worse than the disease, and their liver starts to fail. And so I don't think it's an answer for everybody with cancer and liver failure, but in the kinds of patients who survive years with liver-only metastases, and after extensive chemo and treatment, then their liver starts to fail and they've continued to do well, I think it could play a very good role. And again, like we've said over and over, selection is key. But I don't think it's an answer for every patient with cancer who has developed liver failure. It's a very unique patient, a very uncommon patient who's been able to survive multiple rounds of treatment, typically is otherwise healthy and young. And those are the patients I think we can consider it. And I've referred patients like this, whose livers are starting to fail after years of treatment, but amazingly, they have this unique biology where the tumors, the metastases have only been in the liver. These are probably the ideal patients. They will likely continue to recur at some point, but they'll probably live years. And so if I were, say, 35 years old and I had cancer, colorectal cancer in my liver, and I had a 3-year-old child, living 5 more years, even if my cancer comes back, is very meaningful, unlike if I was a 75-year-old person. So I think there's a role for the young, healthy patient who, even if they will eventually die of their disease, to get them time. I'm not addressing the public health issues of liver availability and cost, which I think are important, but if we assume that we can do it from a public health perspective, I think it'll play a very important role in those patients. And I think, as Federico was alluding to, as treatment gets better, this may play a larger role, because the treatments will eventually be toxic to the organs. So I think that's an important, very important consideration.
Me gustaría escuchar la opinión del doctor Mario Uribe y del doctor Felipe Fernández con respecto, vaya, todos hemos tenido pacientes que tienen un perfil mutacional adverso, ¿no? Son pacientes KRAS mutados, CNRAS mutados, BRAF mutados, y que el poder llevarlos a cirugía va a requerir cirugías sumamente complejas, ¿no? Muchas veces 2 etapas, probablemente ALPS o situación o variantes de ALPS o probablemente, como nos mostraba anteriormente el doctor Ian, cirugía extrema incluso. A su consideración, ¿el perfil mutacional hoy en día debe evitar este tipo de cirugías? Porque finalmente la recurrencia puede ser sumamente pronto e incluso es tiempo que ese paciente va a estar sin quimioterapia. ¿Cuál es su perspectiva? ¿Estamos en ese momento de que el perfil mutacional nos haga detenernos en hacer algo muy complejo?
Bueno, yo creo que una consideración muy importante. Ayer terminamos el Congreso Chileno de Cirugía, vino el doctor Torcelli y nos mostró una muy buena experiencia en cirugía ahorrando parénquima. Yo pienso que en este momento, por supuesto, es un factor de riesgo más para poner en la balanza. En cirugía y la decisión quirúrgica de efectuar cirugía resectiva, en este momento no hay un elemento que diga esto es prohibitivo. Es una suma de factores. Y por supuesto que el KRAS y especialmente el BRAF, junto a otros nuevos marcadores que hay en este momento, el SMAD4 y otros que están saliendo, van sumando elementos. A eso va a también ver qué tipo de resección hay que hacer, la edad del paciente, si tiene otros factores. Yo creo que es un elemento muy importante a considerar. Creo que un paciente que tiene una mala genética, una genética muy desfavorable, no es para hacer grandes aventuras quirúrgicas, pero creo que tampoco se puede descartar o dejarlo afuera. Yo creo que esos pacientes tienen que ser operados y buscar algunos elementos, a lo mejor hacer unas combinaciones quirúrgicas. Nosotros tenemos harta experiencia en cirugía en 2 tiempos. También hicimos ALPS con trabajos publicados, buscando en un momento que el ALPS estaba recién partiendo, así que buscando también algunos de factores predictores y ver qué pasaba desde el punto de vista del hígado, el crecimiento que se tenía. Y por cierto, en este momento tenemos 24 pacientes, 2 de ellos fallecieron. En este momento nuestras restricciones, nuestras indicaciones y restricciones al ALPS son un poco diferentes que con las cuales partimos. Entonces yo creo que hay un amplio camino para recorrer, pero yo creo que es un factor muy importante a considerar teniendo en cuenta estos otros elementos. No es el único, pero sí es muy importante.
¿Algún comentario, doctor Fernández?
Yes, great question. Great question. What we have seen is that what we believe is that BRAF has mutation P53 and some others are coming and being. We consider this one more point for consideration, but not exclusively as a decision-making unique process. So I think you should consider if the disease is multinodular, bilateral, if you have a one margin, you can anticipate a one margin or not, and of course the molecular profile. But if the patient is still resectable and you can take out all the disease, we believe we should go for surgery. We know there are some data discussing maybe if some patients with more than 3 lesions, lesions more than 5 centimeters, lymph nodes in the primary, and some in these mutations, some discuss that maybe there is no role for resection, but we still feel that there are some roles, yes. But of course, you have to see the whole picture, not only the mutation profile. So we think it's resectable, we should go for resection. And it's like, for example, if you have a complete response in a prolonged chemotherapy. But one very important point here is not to resect if the disease is progressing, of course. So you have to have a systemic control of the disease and the possibility to reach out R0 resection, a complete resection, and then you should go for the R0 removal of all the lesions.
Doctor D'Angelica, comentaba al respecto de este perfil mutacional adverso. ¿Cuál es su opinión con respecto a los márgenes? Ya el doctor Botella ha hablado sobre en ablación con KRAS mutado, probablemente dar un margen más amplio. ¿Qué opina en términos quirúrgicos? ¿Debemos evitar un R1 o un margen muy cercano en pacientes que tienen KRAS mutado, por ejemplo? Y en otro sentido, pues hablaba el doctor Mario Uribe con respecto a las resecciones del doctor Torsili, que se ha minimizado un poco el R1 vascular. ¿Un paciente KRAS mutado, BRAF mutado, estaría tranquilo favoreciendo un R1 vascular o preferiría hacer una resección mucho más extensa para evitar esto? ¿Cuál es su opinión?
So it's a good question. I think what Felipe was getting at is very important, and that is, I hope this translates well. Phenotype is more important than the genotype. And what I mean by that is that KRAS is actually not such a bad prognostic sign. Actually, it makes a relatively small difference. And even there are exceptions in BRAF mutated tumors that do very well. So my feeling is you have to watch the patient and see how they do. If you are concerned about their biology, you watch them on chemotherapy, you watch them over time. And if they have an unfavorable somatic mutation profile, you watch them. If they progress on chemotherapy, then forget it. Then surgery is not the right thing. If they're not doing well, then maybe margins do matter more. But if they're not acting like a typical bad patient, then you treat them the way they look. Somatic genes do not give us the answer to everything. The genes in the tumor do not give us the answer to everything. There are plenty of patients with KRAS mutations who do very well, but we need tools to follow them and make sure that we agree that they do well. So I think we have to be careful to overinterpret retrospective data. In my opinion, the one genotype that I do worry about the most is the combined RAS P53 mutation. There is probably something real with that. And those are patients who should be observed on chemotherapy. But sometimes they don't act poorly and they do well. And then I think you should do standard approaches to them and not necessarily worry about margins. To discuss about the R1 vascular, I think in a very favorable patient, we do this. We come very close to tumors. We take them off of vessels. For me, especially with the use of hepatic artery chemotherapy as an adjunct, I would much rather do that than do extensive parenchymal resections and risk death from liver failure. So I'm in agreement with that approach.
Doctor Aucejo, con respecto a la pronta recaída muchas veces de los pacientes con trasplante, con metástasis de pulmón, a veces minimizamos cuando el paciente tiene metástasis pulmonares irresecables. ¿Vale la pena en esos pacientes conseguir un R0 quirúrgico en el hígado a pesar de esa enfermedad extensa en el pulmón? ¿Cuál sería su opinión al respecto?
I think that again, it depends on what type of. So you're talking about presence of involvement, both liver and lung, right? And the surgical approach, right? So I think that it would make sense, especially if you have to do a substantial liver resection, that the involvement in the lung is minimal. And like I was pointing out before, a unifocal or oligofocal disease that you could either resect in the lung or radiate. But if that's not the case and we have more extensive presence of disease, I think then there's no role for much role for surgery, unfortunately. But in terms of how aggressive you should be in the liver in the presence of lung disease, again, it depends also on the form of how the lung is being involved and how you can treat it.
Por último, me gustaría que el doctor Fernández Coimbra, el doctor Mario Uribe me dieran su impresión de qué es lo que qué es lo que ustedes prefieren en un paciente que tiene metástasis irresecable o cuando menos metástasis en todos los segmentos del hígado y responde muy bien a quimioterapia. Sin embargo, algunas lesiones se borran, otras no, pero el paciente tiene un estado funcional excelente. Y los oncólogos médicos nos los envían continuamente para ver si les podemos ofrecer algo. Vaya, todos sabemos el significado de una lesión borrada, ¿no? Que finalmente hay evidencia de viabilidad. Pero ¿qué hacemos con estos pacientes? ¿Cuál sería su estrategia? ¿Más quimio? ¿Una resección hepática limitada sabiendo que se dejan borradas? ¿Infusión arterial hepática puede ser una opción, pero no disponible en nuestros países? ¿Qué hoy ofrecen a estos pacientes?
Bueno, yo creo que es muy interesante la pregunta. Yo creo que si uno pudiera resecarlo, es mejor resecarlo, pero con las metástasis cuando han desaparecido y ya no se encuentran por los medios imagenológicos habituales, yo creo que ese es el problema de la decisión. Nosotros en general no hacemos grandes ciclos de quimioterapia, hacemos 3 o 4, por lo tanto la desaparición de metástasis sería una respuesta excepcional. Vemos que a estos pacientes se les disminuye la lesión, pero no tenemos, es raro que desaparezcan completamente. Pero asumiendo el caso de que tenemos algunas que sí y otras que no, yo creo que uno debería intentar resecarla, tener una buena resonancia específica para poder determinar cuáles de aquellas son más sospechosas de viabilidad, un buen ultrasonido intraoperatorio e ir a una cirugía. Yo ahí sí que soy muy partidario de una cirugía de ahorro de parénquima, tratando de resecar las lesiones que claramente son viables, y las otras, una muy buena observación. Si este paciente fue irresecable en algún momento y han desaparecido por tener metástasis bilobales, me refiero, bueno, es difícil que después, al desaparecer alguna de estas lesiones, podamos hacer una cirugía resectiva de todo lo que había. Entonces priorizaría aquellas lesiones que son más sospechosas, se pueden marcar las otras para tener un buen seguimiento y efectuar, entonces se transforma en una enfermedad ya crónica y ir efectuando resección en la medida de que haya más sospecha de viabilidad.
Doctor Felipe.
Yes, great question again. First of all, we would consider, I think there are 3 ways that we know that would guarantee more closely a complete response, which are MRI with diffusion and liver-specific enhancement. Second is the normalization of CEA. And the third is controversial, but it is intraarterial hepatic infusion. So I think this could be the options to guarantee a higher rate of real complete response. But what we would do in this situation would be to, instead of operating these patients between 4 to 8 weeks after chemotherapy, maybe we would wait a little bit more just to be sure what of these lesions are really active and try to resect them. And of course, during the surgery, resect all the lesions we would find, and also the sites that we would consider having still some disease there. But another option, if we don't find all the diseases, all the lesions, would be to ablate these patients after surgery. For example, if you still have 1 or 2 or 3 lesions that you don't find, and then this patient recurring the same lesion, we could also do ablation after surgery by tomography. But I think one of the most important things here is to try to avoid this to happen. So as Dr. Reed said, or you could mark the lesions with a metallic clip and also do a short course chemotherapy just to be sure that most of these lesions wouldn't disappear.
Bueno, pues en aras de tiempo hay que terminar la sesión. Me encantaría seguir platicando con ustedes. Realmente fue una extraordinaria mesa redonda. Fue increíble tenerlos el día de hoy aquí. Les agradezco a todos, doctor D'Angelica, doctor Mario Uribe, doctor Federico Ucejo, doctor Felipe Fernández. Muchas gracias y los invitamos a continuar con los casos clínicos de hepatocarcinoma que sin duda también serán muy interesantes. Muchas gracias a todos y hasta la próxima.
Thank you so much.
Muchas gracias.